Start on time. Thank you, Justin. We're going to start on time again. Last week's speakers were fantastic in keeping the time limit. So we have 6 great programs that are being presented today, and I'm going to turn it over to Eric Lau, our Chief Research Officer, to sort of moderate the program. Thanks, Eric.
Great, thank you so much, Keith. We're really looking forward to today's talks. Justin, can we have the first slide, please? Just want to remind everyone that our next research town hall for our departments on Tuesday, December 1st. With Zoom, the world is smaller, and we're very lucky to have 2 great presentations. First from Rich Hoden and Mehmet Toner about our revamped faculty mentorship program, so please don't miss that. And we're lucky to have Dr. Mackenzie from ECSF to give us a talk about her work in fetal genetics, and she's an awesome role model for our trainees as a surgeon scientist. And also beginning this coming year, we are instituting a new program. This is called the Resident Academic Development Seminars. Tuesday evening seems to be a good time for the trainees to get together. So the 3rd Tuesdays of each month, we will have a series of talks. In the future, this can be used for T32 projects and your F32 applications, everything from reviewing papers to writing your specific aims and biosketch and so forth. So please look out for that. Next slide, please. And given our talk 2 years ago and all the talks this month, I think all of us, trainees and faculty members, are really energized about career development. Certainly when I walk through the halls and the operating rooms, I'm getting a lot of positive feedback and comments. And for the peer mentorship, it is really in large part due to the efforts of our residents. So we're instituting a new position for our trainees. During the academic research years, we will have 2 academic development admin residents. And then the inaugural residents are Taylor Coe and Jordan Secor. And I'm very pleased to announce that, and we will select 2 more to follow them for the following academic year. So the first talk will be from Jim Markman from Transplant. Thank you.
Well, thank you, Eric. Good morning, everyone. So as Keith mentioned, there were 6 great talks last week, and I'm sure more will follow. But I'm hoping that in the next 10 minutes or so, I can convince some of the residents that transplant would be a great place to work, both for their research years and also for a career. Next slide. So we're fortunate to be in what is probably the best research hospital in the world, and also in the best funded department of surgery, here shown with some of the Blue Ridge rankings. We probably also have the best funded transplant unit in the country, although the data isn't really available. But you can see that Jorn Madsen, who heads up the Transplant Center, or the Center for Transplant Sciences, would be the 2nd ranked surgeon for research funding in the country if we participated in the rankings. And Jorn's not here today, but, so don't tell him I said something nice about him. Next slide. And when you look at the Department of Surgery, the Center for Transplant Sciences has almost $20 million in funding and accounts for about 1/3 of the overall expenditures in the department. So there should be great opportunities in the CTS. Next slide. We're also well supported by the hospital. They recently renovated our animal facility over in CNY to help support our xeno studies. Next slide. And when we think about transplant, I was always told to ask big questions and tackle big problems. Well, we're fortunate in transplant that we have 2 really big problems: not enough organs and the need for chronic immunosuppression. But transplant is also unique in that it is really the only example of rationing of life-saving therapy, I think, that we have in our practice right now. And so there's lots of other issues that are ripe for study for outcomes work and quality improvement, et cetera. And this is a growing part of what we do. Next slide. Probably our greatest asset is the field itself and what's going on in the field with the innovation that's entering the field. And this was captured in a nice piece by Sir Peter Morris some years ago on the 50th anniversary of the first kidney transplant. And he wrote about what had happened in that 50 years, but his real focus was on what's coming and what's happening now in transplant with organ perfusion and tolerance and stem cells and xenotransplant, making the case that what's going to happen in the next 50 years will really change what we do, and there'll be a lot of growth as a result. Next slide. So we have a number of studies working to make more organs available. You probably know most about our organ perfusion work. There's been great success with heart and lung. In liver, we've done now about 50 cases, which I think is the biggest experience in the US, and it clearly shows that the organs that are pumped function better. And it also allows us to transplant organs that previously we wouldn't even consider, because we can put them on the pump and see how they function. This will also make the transplanter's lifestyle better, and that we can leave the liver on the pump and transplant it in the morning instead of doing all our work in the middle of the night. Maybe more exciting, though, is this is a disruptive technology that will allow us to do things that we previously wouldn't have even considered. And a lot of this work that we do in the laboratory with kidney pumps or liver pumps is done in collaboration with a bioengineering team headed by Korkut Ugin. And I just mentioned two projects that I think are quite interesting. One is work by Heidi Ye and Sivash Ragani, defatting livers on the pump. So we throw away a lot of livers because they're steatotic. And so the goal here would be to put it on a pump and eliminate the fat. And this is an example of a rat liver from a fatty Zucker rat, treated on the pump for a few hours with agents to mobilize the fat. And you can see the fat has been largely eliminated. So the team is now working on translating that to human livers with clinically relevant reagents. Another a possibility that I find very, very powerful would be the ability to regenerate the liver on the pump. You know, we can take a left lateral segment off a deceased donor liver and transplant it to a child. But in theory, we could also take that piece and grow it to a size that would be suitable for transplanting an adult. And if we could accomplish that, we could really make a big dent in the organ shortage. So this is work that's just getting underway, but it seems like it should be something that we can accomplish. Next slide. We've also been working with members of the Harvard Stem Cell Institute and Doug Mountain, who now can generate islet-like clusters out from stem cells, either ES cells or iPS cells. It's a complex process with 30 different growth factors and reagents that have to all be timed, and it takes a month to make them. But what they generate really look like islets, and they work quite well. We've now cured 2 different monkeys with these cells, and you can see here the glucose control is almost perfect off insulin with good IVGTT. So there's a lot of work that can be done moving forward with this, understanding how best to transplant these and how to modify the cells so they're non-immunogenic and we don't need immunosuppression. A version of these cells is about to enter clinical trials. We'll be one of 3 sites in the US that are transplanting these cells to patients starting sometime next year. Next slide. Maybe our best opportunity, though, may be in xenotransplant. And I think with the recruitment of Robin Pearson and our partnership with 2 companies that are engineering pigs, I think MGH has become the epicenter for xenotransplant. There's no program that can do what we do when we harvest a pig and have Tatsuo's team transplant the kidney. My team with Shoko transplanting the liver, Joran transplanting the heart, and Robin transplanting the lung. So there's a real opportunity here and a great area for a young surgeon to have a real career effort in this. Next slide. As you also know, we have a long history of working in tolerance with the pioneering work of Ben and David and Tatsuo, inducing tolerance with combined bone marrow and kidney. That protocol, though, requires very intensive conditioning, and I think that's probably why it hasn't caught on. Tatsuo is doing some really interesting work in the lab now with agents that don't cause an ablative approach, or not so toxic, that cause apoptosis just in the lymphocytes. And with this approach, it may be less toxic and a more widely applicable protocol. So this is work that's ongoing and is a great area for further study. We also think that cell therapy, either regulatory T cells or B cells, could induce tolerance. We think these are the ultimate mediators of tolerance and have some clinical trials and some basic work in the lab ongoing. We also have a number of immunomodulatory treatments with different companies that we're using to try to get islets accepted without systemic immunosuppression. So another area that has great potential. Next slide. The Transplant Center has a robust clinical research effort, 55 total studies in progress. More than 200 patients were enrolled last year, and the success of our clinical research really comes from this team of clinical study nurse and nurse and clinical and study coordinators, and they make it very easy to do clinical research. And I think that's why it's really thrived in our program. Next slide. As mentioned, we also have a growing outcomes program, and I think this has really been bolstered by the recruitment of Leanne. But Heidi, Nahel, and Leanne are all working on this and have a large number of different projects in progress. Leanne's working on a medication and wellness intervention for fatty liver disease, which is quite timely given our growing population of those with NASH. Heidi has a number of studies, including peer support for adolescents in an attempt to improve health-related quality of life. And Nahel working with our patients to understand the willingness of them to accept Hep C positive organs and the outcome in HBV, just to name a few studies. Next slide. We have lots of industry partners. It seems like we get a call every few weeks from a company that wants to work with us to take advantage of the perfusion model or the large animal model. I won't go through these, but there's a lot of opportunity here for innovative work. Next slide. Also for residents who work in transplant, there's a great opportunity to hone their surgical skills. Here we have Taylor and Maggie removing organs from a pig. These are demanding procedures and really great training opportunity. Also, the residents that work in transplant help our fellows recover organs. You can see some have taken great advantage. Chuck Rickards did 73 multi-organ recoveries while he was in the lab. And certainly Chuck is a better surgeon for it, I'm certain, and I'm sure he'll teach UCSF how to do it right. So really a great opportunity for the residents. Next slide. So I hope I've convinced you that CTS has a lot to offer for residents for their research time. It's a very experienced group, a great history with Dr. Russell and Ben and the others along the way. A real track record of success. We have basic translation and clinical opportunities, ample funding. There's also a longstanding T32 grant that I think Ben and Dr. Russell started more than 20 years ago that provides 3 slots for postdoctoral positions in the lab. And I hope also you see that transplantation is a real growth field. We're going to be doing a lot more in the future. It's rewarding, open, life-saving surgery. The lifestyle will get better. There's also a great research opportunity. And we have a real multidisciplinary approach and a team-based practice. Next slide. So we'd be happy to talk to any of you interested in working in the transplant labs. We currently have 4 residents in the lab, which I think is a testament to what's going on in the field and the interest in transplantation. We've also had a lot of interest from other programs sending residents to work with us because they know what's going on here. We have 2 BI residents right now. Joran has a recruit from Emory, and Dan Furl came up from Duke. Dan's time is interesting. He wanted to learn CRISPR, so he's actually spending the first year working with eGenesis, designing his own pig, and hopefully in the following years of his time, he'll be able to transplant some organs from that animal. Next slide. So I hope you'll all think about transplant. Thank you.
Thank you so much, Jim. I've had the opportunity to tour the night surgery recently, and it's really amazing work going on. And obviously, both on the research side and the academic development side, transplant is a fantastic opportunity for our residents. I have had the privilege to have been mentored, but not just one, but 2 Dr. Austin. So it's really a distinct pleasure to introduce Jay to present for our group.
Thank you, Eric, for the opportunity. Obviously, 10 minutes, as you've seen, is impossible to go through all the various efforts and projects in plastic surgery and burn. But, you know, as I now have a new boss on the research side, Dr. Liao, I think he'd want me to make 3 points, and I'm going to make them before I start. One is plastic surgery and research, just as in our clinical work, is extremely diverse, and there are almost no limits in the areas in which we are able to do our research. 2, secondly, we've always been run and focused on general surgery residents. Still to this day, our work is mainly being done by general surgery residents. And the third point, which is really critical, is that you don't have to be interested in plastic surgery. We've had many come through who don't know what they want to do, decide to do or actually do know what they want to do, that it doesn't happen to be plastic surgery, and have been very successful working with our group, and hopefully you'll get a sense of that through this presentation. Next slide. So all the members of our group are involved in the various elements of plastic surgery research. Next slide. On the basic side, I really can only hit some of the highlights. Again, as in our clinical work, we're able to work all over the body and in all patient populations in our area. Kurt Cetrulo and Dr. Randolph, as you know, continue their work with transplant. You've just heard all the exciting work there. And Kurt, of course, is applying many of what you've heard towards the field of VCA. Many of us think that might be the future of reconstruction. We've now developed with the addition of Dr. Valerio, Dr. Eberlin, Dr. Cetrulo, Dr. Winograd, and Mark Randolph. Many think we have the most robust nerve basic science laboratory in all of surgery, and a lot of exciting work going there. My group continues to focus on various aspects of translational research. And of course, Dr. Liao doesn't need a big introduction. On the translational side, we're spending a great deal of time on device development. We have many various clinical trials in the area of nerve, breast reconstruction, and migraine. And we're continue to build up our funding, now have over $2 million a year. Next slide. And here you can see that our funding continues to grow like many of the groups. Next slide. So Dr. Cetrulo continues to develop our clinical program. And although our numbers are low, the quality has been high. He and the group performed the first penis transplant in the United States, and that continues to have success, and is working on elegant solutions for face transplant. In the laboratory, he's been working on numerous areas, particularly on improving the issues of ischemia, but also on the various elements of rejection, using CAR-T and mixed chimerism, as well as some of the other protocols that you just heard from Dr. Markman. Next slide. John Winograd continues to develop his nerve program, not just in the basic science area, but also clinically, and now is embarking on DoD-funded clinical trials. And all of his work has and continues to be performed by general surgeons. Next slide. Dr. Bojovic is making really incredible inroads in the area of laser. We've known for years that the laser is a very powerful tool, but now he and others, including, as you'll hear in a minute, Dr. Friedstad, are really delving into the genetics and epigenetics of what's going on and how we can better use these tools to improve burns for drug delivery and in areas even hair growth. Next slide. Dr. Liao, again, needs no introduction, but he is really the quintessential surgeon scientist. He has a tremendous group of researchers who are identifying congenital anomalies, sorting out what genes are involved and what they do, and of course taking that to diagnosis and treatment. And his group includes not only PhDs, but now a Mass General surgery resident, John Mitchell. Next slide. My own lab continues to focus on translational projects. We've spent years looking at what we can do with photo tissue passivation, the use of photoactive dyes and light to strengthen tissue. And our latest company, Dervina, we've just closed funding on $3 million for that, and we're going to solve the problem of vein graft stenosis. We're working with Boston Scientific on the development of endosurgical devices to prevent problems from submucosal resections of tumors. We continue to work on what we're able to do with fat, and our migraine team is really the most productive team in the world in this area, with more than 10 publications in the last year, multiple clinical trials and a multi-center trial. And if you look at all the companies that we have, we've raised, actually by the end of this week, over $100 million in funding, and created over $200 million in value. And I continue to think that this area is actually quite important. If people don't want to pay for it, it's hard to get your ideas to patients. And, you know, our fellows can get involved in those aspects of the work. Next slide. In the area of burn, everyone continues to make inroads, particularly in the area of clinical research. And we continue to be a highly sought after site for clinical trials in particular. Next slide. We've received 3 outside grants in the last year and more than 60 peer-reviewed manuscripts in the past 2 years, and of course, many presentations. Next slide. The funding also continues to be robust with over $300,000 in funding per year. Next slide. Dr. Governman continues to run really excellent trials. One of the more exciting areas that he's been involved with is in the NexaBreed technology. This is an enzyme that debrides wounds without going to the operating room, and really promises to dramatically change how we treat patients. And very excitingly, he's been able to place xenotherapeutics gal knockout pig skin on human patients for the first time. And this is the culmination of many years of work of David Sachs and the transplant group. Next slide. Dr. Friedstadt is quite interested in the genomics of what's happening with the laser and has DoD funding for this. And this area really promises to be very exciting in the area of scar and rejuvenation. Next slide. So the residents, and that's really the point of this talk. You know, we have many surgery residents in all of our laboratories. And in the past, most of them were Mass General residents. Unfortunately, you all don't get much exposure to us. You don't rotate through our service anymore. And so we're really pleased for the opportunity to just give you a glimpse at our work. But in the past, our fellows have gone on to great success. And as you see here, fellows such as Rob Goldstone and John Mitchell don't necessarily have to be particularly interested in plastic surgery to reap the benefits of working with our group. Next slide. We're very focused on career development. And for those interested in plastic surgery, we certainly have a very comprehensive program to develop your knowledge base in that area. But for those who have other interests, we certainly are able to utilize all the resources of the department. And, you know, it's a two-way street. We're very focused on making sure that whatever you're interested in, you learn study design, how to write papers, grants, and mentor medical students. And in recent years, we've learned to be very collaborative. People come into our laboratory and they have a particular focus, but they have the ability to work with different mentors depending on the activity of the various projects. So people can really be as busy as they want in the basic science area, as diverse as they want, and get involved with clinical projects. So that's it. I hope I'm under 10 minutes, and thanks for the opportunity to present some of the work of our group.
Thank you very much, Jay. I would say, obviously I'm biased, but I think Jay has really built the top plastic surgery program in the country, both on the clinical side and also the research side. So if anybody's interested, please come speak to us. We'll be happy to show you more of what we do. Next, I'm really pleased to introduce Alan Goldstein. Certainly been not only a role model, but also a friend and colleague over the years, to really a great role model for all of us that aspire to be surgeon scientists. So Alan, please.
Thanks so much, Eric, and thanks for the opportunity to present the research in pediatric surgery. Next slide, Justin. Well, first I have to start with, I could probably spend all 10 minutes just introducing Dr. Donahoe and talking about her career, but suffice it to say for this, that she is the director of the Pediatric Surgical Research Labs, which she started over 40 years ago and has been continuously NIH funded. I would point out, there's the 2 bullet points at the beginning. The Pediatric Surgical Research Labs has 2 main goals. First is to analyze genomic, transcriptomic, and proteomic data sets to understand the development of congenital anomalies. And secondly, to utilize stem cell and gene therapy-based treatments for pediatric surgical disease. Dr. Donahoe's main focus is the genetics of birth defects. And for, I think it's been 17 years now, she's had a program project funded by NIH to study the genetic causes of congenital diaphragmatic hernia It's a very robust program that goes all the way from patient phenotyping and recruitment to developing novel potential therapies. Next. My group, and I work very closely with Dr. Rio Hara, who's he's a pediatric surgeon by training and is a full-time scientist on our faculty. We study the enteric nervous system and Hirschsprung's disease. On the left, you see one example of an animal model we use with Hirschsprung disease. We have other models of neurointestinal diseases, whether it's gastroparesis or other types of dysmotility. For many years, we've studied the development of the enteric nervous system, both in avian embryos, which is the picture of the embryo at the top, and also in mouse embryos. The transcriptional profiling of the ENS is a relatively new area that's been sort of led now by Rich Geyer. Rich is trying to identify sort of the different subtypes of glial cells and how they fit into the picture of enteric nervous system development and disease. And on the bottom, just an example of gut motility. It's a movie that streams there. We do a lot of physiology, studying electrical activity and motor activity in the gut, normal neurointestinal models. And then on the next slide, our real goal is to develop novel cell-based therapies to treat Hirschsprung's disease, which is the absence of neurons. And so one real treatment would be to replace those missing neurons. We do that. In the bottom left is a mouse that has Hirschsprung disease getting implanted with neuronal stem cells. And on the bottom right is we're translating that work now into pigs with support from Takeda Pharmaceutical that really wants to see this go into human trials within the next several years. Next. David Pepin's one of the young investigators on our faculty, and he has taken on Dr. Donahoe's efforts in malaria inhibiting substance. The malaria inhibiting substance, as you know, it takes away the Müllerian structures during development, and he's leveraged that for two main goals. First, obviously, it causes ovaries to shrink, and it turns out that with some very elegant work, he's shown that MIS can be used as a novel contraceptive, and secondly, as a mechanism for oncofertility, which is protecting ovaries of young women during chemotherapy. And secondly, it also causes regression of, or prevents uterine development. And so he's taken advantage of that to do some work using a combination of organ-based models and transcriptomics to identify a novel stem cell for uterus development. And it's helping to understand a lot of the causes of Müllerian anomalies. So really innovative work using Müllerian inhibiting substance, which has been the legacy of the pediatric surgery labs for decades. Next. Casper Lage works in the pediatric surgery research labs as well, which is housed over in Simke 6. And he's a computational biologist who does very innovative work in bioinformatics. He develops novel platforms to study genomic, transcriptomic, and protein-protein network data. And then on the bottom there really takes advantage of those by his collaborations with people in translational work to discover pathways in disease pathogenesis, and has applied that to a variety of diseases from arrhythmias to cancer to psychiatric illnesses. He consistently, as you can see, publishes in Nature journals. The work is really of the highest level, and he's eager to work with residents in our department. Next. In addition to all of the basic science that defined pediatric surgery here for so long, thanks to Casey Kelleher, we've really built a robust health services research program over the last several years. Casey's main interests are in employment equity in surgery, specifically in gender equity among surgeons in terms of their employment. And secondly, surgical appropriateness in pediatric surgery, and how we make sure that we use evidence-based care in providing surgical care to children. She also got us involved with the Eastern Pediatric Surgery Network, which is a new consortium of children's hospitals along the East Coast, 10 institutions that are studying really important topics in pediatric surgery. Many of the things we do happen in low volume, and so these multi-hospital consortiums are really critical to gather real data. And Cornelia Griggs just joined us recently and is working with Casey on the EPSN, and also brought to MGH COSMIC, which is the Childhood Obesity Surgery Multi-Institutional Collaborative that is housed at Stanford and Columbia, and now MGH as well. Next. Peter needs no introduction. Peter Masiakos is a national leader in legislative advocacy and injury prevention. He has a real focus on gun violence prevention, a very productive research effort, a lot of involvement from our residents, and it covers everything from research to working with the legislators, education, and community engagement. Next. The pediatric surgery labs is, around the world, this department, this division of pediatric surgery is known for the research productivity that it's had, largely thanks to Dr. Donahoe and everyone that she has mentored and trained. We have collaborations all over the world, a lot of regional collaborations and funding from many sources, both federal funding foundations and sponsored research agreements with industry. NIH is the largest funding group. We have Rich Geyer working in the basic science side now. Maggie Westfall recently worked with us on the health services research side. Numa Perez is very involved. So we've had lots of residents, lots of interest, and we're always eager to help our residents advance their academic goals. If anybody's interested, just send me an email or call me. Thanks again for the opportunity, Eric.
Thank you, Alan. Thank you so much. Really amazing work going on in Simkes. For people interested, please reach out to Dr. Goldstein. Next, we'll hear from George Baumhost for the trauma group.
Yes, thank you, everybody. This is a snapshot of the research that we're doing in trauma, emergency surgery, and surgical critical care. You can advance, please. So the backbone of our research is our International Research Fellowship. These are people who come from around the world through a competitive process. We receive about 70 to 150 applications every year, and we really select the cream of the crop from around the world to come and work in research with us. These are people from Denmark and Lebanon and Israel and Turkey and Greece and Egypt and Thailand and from around the world to come. Many of them want to enter into residency programs at the end, but they give their heart and soul for 2 years with us doing research and excelling in every aspect of it. Next. And these are our great residents. These are the ones who are working, who have active projects with us right now, Trey and Casey and Imani and Lydia and the ever-present Kat and Hassan Mashbari, our fellow. We have had a great record with the residents who have come through the division and their research output, the product, their studies, and we really rely on the residents to not only produce studies, but to present in national forums and put the division forward. And these are our faculty. There are no exceptions, really. Some of them are doing more research and some of them are doing less, but we do not have faculty that do exclusively research. We all have a smaller or greater clinical perspective in our lives, and we have a research perspective too. I happen to believe that great surgeons exist everywhere in every hospital of this world, but the responsibility in this place at MGH is that all surgeons have an academic engagement, and all of our faculty have some academic engagement, and they produce research. And these are two people that need specific mention. This is Carrie Breen, who is actually our study coordinator. She is behind the organization of our research protocols and the IRB approvals, and in general, the coordination of our team. And of course, Haitham, who is truly the heart and soul of the research program. He's behind all the effort. He's the enabler and the coordinator and the person who is there on every research meeting, mentoring the new people, thinking of new projects. He's an amazing academic force in our division. We hold weekly research meetings, and don't ask me about this first bullet. Each meeting starts with a proverb. This is a Kafarani item. He has everybody start the meeting with a proverb from their own country. It makes for a light-hearted start of every research meeting, but we present studies there, and we give feedback to our research fellows and to our residents, and we rehearse all the studies that are to be presented in conferences. This is a weekly forum that we hold, and in the past, as you see, we were having 20 to 30 people every week, all meeting together in our conference room. Nowadays, of course, it's done by Zoom. That's the breadth of our research, and we are lucky to have 4 people with MPH degrees in our division. Haitham Kafrani and Jerome Lee and April Mendoza and John Wabajire, and they are all experts in big data massaging, which is the name of the game this in the age that we live in. But we also are heavy on clinical research. We engage in multi-center studies, many of which we lead. We have a healthy portion of basic and translational research in the animal lab, where we particularly investigate bleeding control methods with innovative techniques like nanoparticles and self-expanding foams and magnetorheologic fluids. We do industry-sponsored clinical trials, not only because we believe that some of them are really good, but because also they bring money to the division that help fund many other projects. And of course, nowadays we got engaged with the biobank, and I will show you some examples of that. For about 15 years, we were producing a steady number of 20 to 30 peer-reviewed publications every year, but now you see that we've gone, we've really increased the output over the last years, and recently in 2020, we have almost approached 90 peer-reviewed publications. These are publications in good surgical journals, peer-reviewed journals that are done by the group. Here are some examples. This is our engagement on artificial intelligence projects. You probably have heard about Potter and the work that we've done with one of the premier predictive algorithms MIT group, where we're trying to predict outcomes in a very, very different way than it has been done so far. And it has led to many publications, and we're expecting formal integration with Epic and with MGH systems in order to put that into our daily practice. Next is our work with the biobank, and here you have a genomic analysis of one of the most common diseases that we do. Here is a typical example. You see the first line of the names that have worked in this project: Alex from Denmark, and Apostolos from Greece, and Carrie from the United States, and Majed from Lebanon, and Charlie from Denmark, and that's how it goes. This is almost how each one of our project goes. Next. This is Casey being the first author on a project in Peter Fagenholz's territory with necrotizing pancreatitis and the benefits of a step-up approach. Next. A multi-institutional trial headed by Haitham Kafrani on an extremely important topic, showing that for some reason the American population is more sensitive or more brainwashed to use pain medication. An extremely important project with implications, with very important implications. But you see how it goes here on these multi-institutional projects. If you get the first 5 lines, you will see, Lebanon and Thailand and China and the Netherlands and Egypt and Mexico and Denmark. You will see all sorts of countries. They used to be research fellows of ours who now are gone back to their countries, and they contribute to our multi-institutional trials that we lead. Next. And here's a basic translational research example of the expanding foam for bleeding control, the David King's long-term project. Next. And another project showing our collaboration with industry in producing multi-center trials. Next. And finally, our recent preoccupation, of course, with COVID and the multiple articles that we've produced surrounding COVID and surgical disease. Next. But again, the backbone of our research is our International Research Fellowship Program. You will see our research fellows in the interview circles today competing for a surgical residency spot. Thomas Peponis was a product of this program, our resident now. And because we do believe that it's not just work, but it's life too. And we all pay importance to well-being, to real well-being. We spend time with our research fellows. In the past, we were spending time in the good Boston dining scene or by the river. Nowadays, it's only Zoom, but we do hope that better days will come. Thank you.
Thank you so much, George. It's really been exciting to watch your group thrive and grow both and lead really nationally and internationally. So please reach out to George if you have interest in the research that he described. Next, we'll hear from Ahmet Toner, who really leads one of the most exciting and one of the most successful research programs in our department. And you'll hear about his advances in engineering and medicine with microfluidic technology. So Ahmet, please.
Thank you, Eric. Good morning, everybody. You know, I would actually like to start by asking a simple question. Why does a bioengineering center within the Department of Surgery, and what does it have to do with surgical fellows? Second question is easier to answer. We have had over probably 100 fellows over the last 2 decades from all over the world, including the Department of Surgery. So it's and I hope I will convince you that there are really great projects you can work in within the bioengineering center. The other question, actually, why is a bioengineering center in the Department of Surgery goes back. The genesis is Dr. Jerry Austin. Wonderful to see him in attendance here. I wish it was in person. And many of you may not know, but Dr. Austin is actually a graduate of mechanical engineering at MIT. Himself is an engineer and was one of the pioneers in heart-lung machines and intra-aortic balloon pumps. And he recruited Doctors Tompkins and Yarmush some time ago to come to Mass General. Dr. Tompkins led surgery division of burns and trauma for many years, and Dr. Yarmush started the research program, and they recruited me soon after. So we built this center over the last about 3 decades. The center has currently, next slide, 16 multidisciplinary faculty. And typically at any given time, we have 80 plus trainees, fellows, and students, and more than 50 collaborations within the Department of Surgery, burns, trauma, transplantation, plastic surgery, but also beyond the Department of Surgery. The mission of the center can be described very simply. We are interested in solving complex clinical surgical problems at the interface of multiple disciplines. This is a new name now, like anything else. It's called convergent science. On the left, you have the fundamental disciplines that we have in our center. These include metabolism, immunology, genetics, stem cells, but also things like biomaterials, microfluidics, transport phenomena. On the right, a list of some of the projects that are ongoing, from organ banking, which you heard from Dr. Markman, nanotherapeutics, inflammation, regenerative medicine, and diseases of the skin. What I would like to do is just give you, it's impossible to go through all the programs, but give you a sense of 4 or 5 of these exciting projects, and hopefully entice some of the surgical fellows to join us. Next slide. One of these projects that, again, Dr. Markman mentioned in his presentation earlier, we are very interested in solving one of the major issues in transplantation, banking organs. Today, heart can only be stored for 4 hours, most organs less than 12 hours. That is not compatible with current immunomodulation therapies. We need to do days, if not weeks of storage. We are borrowing from nature to solve this pressing problem. For example, Cayman crocodilus, it can supercool. In other words, you are in liquid water state, but you are sub-zero. Remember, last night the temperature was 20 degrees Fahrenheit, which is about -3 degrees Celsius. So they actually go lower than that. And because the temperature is lower, you can go into suspended animation for longer durations and work with Dr. Markman, Dr. Ye, as well as Kurt Cetrulo and Joran Madsen. We are trying to mimic this in mammalian organs, and we have success with the rat liver for 3-4 days, human liver for about 27 hours. Much of this work is led by Dr. Korkut Uygun, as also Dr. Mark mentioned. If you want to go longer, you need to go lower in temperature to -10, -30 degrees Celsius. Just to give you a sense, -30 degrees Celsius is about 50 degrees cooler than last night. So if you are planning to go skiing, don't do it. And unless you are a frog called Rana sylvatica, because those animals can actually go to this temperature. They partially freeze, but they freeze in a very systematic fashion. So we are mimicking the way they do that so that we can go to these lower temperatures to get a longer duration storage. We are also using zebrafish as a model system. Shannon Tessier is leading these studies where we could screen, as Dr. Eric Lea is doing in his work for cleft lip pellets, and use it as a rapid screening tool. In the next slide, we also have organs on a chip studies led by Dr. Berk Usta, and we pretty much build whatever organ you want and put it on a chip. We bring techniques of microfabrication. You see the video on the left, and you don't have to be an engineer. Surgical fellows work with teams of engineers to do these things, but we have liver on a chip, brain on a chip, allergy on a chip, even more recently, things like CAR T cells on a chip. Red cells are tumor cells from the patient. Green cells are CAR T cells attacking the tumor cells, so you can do personalized CAR T cell testing platforms. Next slide. One of the exciting areas, and you heard this last week from Dr. Harold Ott, which is one of the strongest research programs in any department of surgery in the world, is creating engineered organ substitutes. The idea is you take a whole organ, you decellularize it, get rid of all the cells, but you need to do that in a very peculiar way so that the vasculature and molecular structure is not altered. And then you repopulate that with cells from the person as well as stem cells or iPS cells to basically you do a personalized engineered organ. And again, Dr. Başak Uygun was leading these efforts with Dr. Jim Markman and IDA in liver area, but also a VCA with Kurt Cetrulo, as well as nipple face and other extremities. Next slide. We also have a number of fundamental biological studies. I want to mention two of them. Dr. Irit Adine is working on not necessarily the genetic aspects of it, but the molecular biology aspects of immune modulation in racial disparity. She is using diseases that are more common in white people, such as macular degeneration, as well as those that are more common in Black people, such as keloid scarring, and try to understand the molecular underpinnings of these diseases. Mariana Bay is very interested in the molecular genetics of skin and its appendages for a number of targeted conditions, including skin wounds. So there's a very rich basic biological team that that fellows can join and work with. Next slide. One of my areas of interest is circulating tumor cells. As you know, cancer kills because it spreads all around the body. And maybe many of you don't know, but human body has about 37 trillion cells. What you probably don't know, 85% of those cells are actually blood cells. You have 30 trillion blood cells. So we are all basically blood walking. And how do you find extremely rare cells that sneaked out of the primary tumor and causing metastatic niches? These are 1 in 10 billion cells, 1 in 100 billion cells with cancer center, as well as pathology department and surgery department. We've been working over the last 20 years, typically several thousand patients a year, 40 plus collaborators to find these cells so we can do high resolution imaging, ex vivo culture for drug sensitivity, personalized oncology, single cell RNA-seq to understand their biology, as well as come up with RNA-based molecular disease signatures. Shamala Maheswaran and Daniel Haber are 2 collaborators on this project. And we also developed chips to find occasionally these circulating tumor cells travel in clusters. That is really bad news. If they are in clusters, their potency is significantly higher and the survival of the patient is significantly lower. So we are looking into how we can find those clusters in circulation. In the long run, what we would like to do, this is what we do from 2 tubes of blood, 20 milliliter out of 5 liter blood. Can we interrogate the entire blood population? 30 trillion cells. And can we find these circulating tumor cells in larger numbers so we can go to early detection, better culture, but more importantly, replace biopsy with a true liquid biopsy. So we are working on that. Avanish Mishra is one of the leaders of it, where we use actually leukapheresis product that could interrogate 2 liter to 5 liter of the blood to beat the odds against the statistics so that we can find thousands of these cells to do studies we couldn't do otherwise. In the next slide, one last example. We also have a lot of emphasis on global health. Dr. Rebecca Sandin is leading these studies with a number of exciting collaborations. They fall into 2 categories. One is biostabilization. Although many of these diseases are very common, cryptosporidium, malaria, they are seasonal. They are in resource limited areas. It's very hard to do research. It's almost impossible to do drug screening and development studies. So we are working to develop ways to stabilize these biological materials. And recently you've been hearing because of COVID and the new vaccines, how important to be able to stabilize these biological materials so we can distribute it around the world to do studies and drug screening. Another area is point of care diagnostics with asymptomatic malaria, as well as HIV drug adherence. And HIV drug adherence work is now in clinical trials, going into clinical trials in Durban and other places. So there are a lot of opportunity here for fellows to travel to resource limited area and work in global health problems. Next, let me give you some metrics of our laboratory numbers. We will publish our results very effectively, and over the last 20 years, we have published over 1,200 papers. Many of them made it into the cover pages and with a H index of 86. And we do this by creating small teams in the lab with surgical fellows, engineering fellows working together, shoulder to shoulder, to address some of the problems I mentioned in the last 5 minutes. Next slide. Our trainees have done very well, and most of them end up in academia. Many of them are now independent scientists, professors at MIT, Harvard, Stanford, Rutgers, Lehigh, Northeastern, and many other places also around the world. But some of them also choose to go to industry, and they're in leadership positions in Novartis, Takeda, and other pharmaceutical companies. Next slide. And there are a number of spin-offs from the activities within the center. So there are innovation opportunities, work in innovation and entrepreneurial opportunities for our fellows. So we will invite them to actually explore these kind of activities within the center. Next slide. This is not as appealing as the wonderful slides my dear friend and colleague, Dr. George Velamos showed a few minutes ago. And his slide was much nicer, but we do have a family. In the end, what matters is the fellows and trainees and having a happy life together so that we can tackle these complex problems together. If you have any questions and interest, please reach out to me or any of the faculty, but also I gave you Lynn and Ilana's email addresses below. They will be the right place to start. Thank you, Eric.
Thank you very much, Mehmet. I think it's clear that he has answered his own questions, that the Center for Engineering Medicine is really a great place for all of us to collaborate. And it's very clear that we all are many of us are affiliated with this group. It's really provides wonderful training for our residents. Next, we'll hear from the Surgical Education Research Group. And to lead off will be Dr. Denise G.
Thanks, Eric. Hi, everyone. Thanks for giving us the opportunity to share a little bit about our work in our Surgery Education and Research Group. This is led jointly by myself, Dr. Fidiakan, and Dr. Petrusa. Next slide, please. So we're really excited to talk a little bit about our program, which is a little different than what you've heard throughout the morning today. Our Surgery Education Research Group really offers a different and unique experience that allows residents from both within MGH nationally and internationally to explore and develop their own specific interests in surgical education, instruction, assessment, innovation, as well as surgical simulation. And I think what's really unique about our work is that we allow our fellows to have a lot of flexibility in how it fits with their research time. So we offer both full or part-time opportunities, and these fellowships can be 1 or 2 years and can be done in conjunction with other research interests as well. And during this time in this fellowship, sorry, that last slide still, please. We allow a time for mentored research projects, and these generally come from the fellows themselves. So it's really whatever the fellows are interested in, we're able to help them develop and reach their goals and what they'd like to investigate. There's also a lot of opportunity for practical skills development, including teaching opportunities for medical students and residents, as well as the opportunity for curricular development. And then the backbone is based on a structured didactic curriculum that runs throughout the year on a monthly basis, where we follow a didactic schedule. And at the end of the fellowship, the residents or fellows can obtain an American College of Surgeons Accredited Education Institute certificate. Next slide, please. So it's really remarkable what we've done. We've only been in existence for about 4 years or so, and the breadth and depth, as you'll see in the later slides, of what our residents have accomplished is really quite remarkable. We started out as a fledgling little group of a few people, and now we're really, prior to COVID, going to meetings and really quite a force, and our entire MGH education group has really made a name for itself. And so the areas that we focused on can be divided into both technical and non-technical skills. On the technical skills side, it's not just an opportunity to work with residents and medical students practically on a day-to-day basis, but there's also a lot of research that we've published on that span areas such as task trainer development, fundamentals of endoscopic surgery, curricula, robotic surgery, as well as developing things like a library of video-based education modules for core operations. And then on the non-technical skill side, our residents come in and they come in with a lot of varied questions that they want to look into. And so we've hit upon and published upon many topics that are very timely, and you can see them on the right side. For the interest of time, I won't read all of them, but things like emotional intelligence, resident autonomy, patient satisfaction, fundamental concepts in the business of surgical care. So these are not traditional topics, but all areas that are very timely, and our residents have been very successful both on the podium and in publications. I'm going to pass this over to Roy now.
Thanks so much, Denise. Good morning, everyone. So as Denise mentioned, I think our track record so far has actually been quite impressive, especially given that we are such a small group compared to some of the other presentations you heard this morning. And the fact that since we allow the residents and fellows to really pursue whatever they are interested in, we are essentially starting over with each fellow, and we do not have these dedicated research lines like some other groups do. We've had about 85 national presentations so far. Published around 97 manuscripts with another 23 that are under review or in press. and are essentially teaching national courses or workshops every month, which I think is also a testimony to our group. Lately with Zoom, it seems like it's weekly. Next slide. And our past and current fellows, these names I think many of you will recognize, but obviously if you have any questions about the program, I highly recommend you speak with them. Taylor and Kristen are second-year fellows right now. Kristen is a Mayo Clinic resident who came here to work with us for 2 years, and then Trey and Roe are our first-year fellows. Next slide. Here are their pictures in case you don't recognize who they are. But the bottom line is that we really are looking forward to working with you. And again, as Denise mentioned, we really want to help you achieve whatever goals you may have along education, be that education administration, you want to be a clerkship director, a program director someday, you want to do the research, or you're just interested in doing more scholarly teaching with program evaluation. So we look forward to working with you. Thank you.
Roy, I just wanted to add one point that our group, we had a research meeting yesterday that they made the point that if you look at these fellows and look at their CVs after spending time in this fellowship, a lot of them have launched their education careers from a lot of the work that they've done during their time off. So we really look forward to working with anyone who's interested in following in similar footsteps.
Thank you very much, Denise and Roy. I put in the contacts in the chats the contacts for all the presenters today. For those of you without partners email, I think there may be some students on the call right now. So feel free to reach out to our presenters. I think we're all inspired by the presentation this and last week. For all of our junior residents, please email me with your career development plans. Please put your name in the file name so that I can easily identify who's who. And I look forward to seeing everyone for our research town hall on December 1st. Thank you so much.
Eric, let me just close by saying something I've said many, many times, is that it's always easy to be proud of this department, but having heard the great presentations for the last 2 weeks and the plans that were being put forth in the grand rounds the week before that, it is so impressive. And I want to remind everybody that not only are these presentations important message to share with amongst our residents who are thinking about the research opportunities, but 2 weeks from tomorrow is our first intern applicant interview day. And we have a tremendous group of about 75 people coming in to be interviewed. Many of them have already accomplished a tremendous amount in research, but we want to be able to sell to them that this is not only the highest funded research program in the United States in the Department of Surgery, but it's one with a broad depth and breadth that we can find something that should attract almost anyone in any field. And so please remember the highlights of this as you spend time meeting with these candidates. Eric, again, thank you for putting this together. Thank you to all the presenters in both weeks for great presentations and keeping on time. Have a good, there will be nothing, just a reminder, there are no grand rounds next week. So please, everyone have a happy and safe Thanksgiving. If you travel, be careful. If you join family, please, again, enjoy that opportunity, but be smart, be careful.
Thank you.